Now, are we live?
Yeah, we are just live now.
So we are live.
All right. Hello, good afternoon, everyone. Welcome to today's masterclass for family physicians. This is presented by SRCC Children's Hospital, managed by Narayana Health. I'd like to thank on the outset the organizing team, Dr. Rasik Shah, Senior Pediatric Consultant, Dr. Sonu Udani, our Senior Medical Consultant, as well as in charge. And also, I'd like to welcome the two moderators. One is myself, Dr. Avisha, consultant pediatric orthopedics, and Dr. Pooja Mehta. She is the consultant pediatric neurologist. Welcome again today. And today's topic is avoiding dysfunction in children. And we have a eminent speaker, Dr. Amrish Vaidya, who is a senior most pediatric surgeon who has more than 25 years of experience, and his field of experience and his expertise is more in pediatric and neonatal urology. And today he will be discussing about avoiding dysfunction in children. I'd like to welcome now Dr. Amrish Vaidya to please start his topic.
Thank you, Avi. And welcome to all of you on this very wet and rainy day. It's what with COVID and the rain, it's really a challenge living in Mumbai, but I hope we can forget all that for the next 1 hour and enjoy this session. So what I'm going to be discussing today is a situation where parents come and tell you that their child's voiding pattern has suddenly gone awry. I mean, there are parents coming all the time to say, suddenly my child is peeing all the time, what's up? We are going to look into the causes of this and see how we can assess this and how we can understand all this. So before we talk about what can go wrong with voiding in children, I think it's important to understand what normal voiding in children is. And from what age onwards can we expect some kind of a pattern in voiding? How does normal continence really develop in children? So the maturation of micturition starts in the neonatal period and goes on. See, when babies are small, they have something like an automatic bladder. When their bladder becomes full, there is a reflex that is mediated through the sacral spinal cord, and that bladder empties. So full bladder, empty bladder, once every hour in neonates, babies just tend to void urine as soon as their bladder is full. But beyond 1 year, there is an inhibition of this, and there is an increase in the bladder capacity. So the number of voids per day decreases to 4 to 9 by the time they get to be 2 years of age. Actually, voluntarily control over micturition happens after the age of 2 years when bladder fullness is actually appreciated. Here, children sense that their bladder is full, but they can't still hold their urine. There is this urge to pass urine. They may indicate that they want to pass urine, and then suddenly the urine is let out. But by the time they're 2 to 4 years of age, then there is voluntary control over bladder, and then you can say that they are truly continent. So the stages in development of normal control are that first they will get control over nighttime stools, then progressively over daytime stools, then they get control over daytime urine, and then nighttime urine. And for many parents who have to live through this, who have to live through nappy changes and diaper changes, they will say that that is the longest battle and the most challenging thing that they face as their babies are growing up. So when the pattern of voiding deviates from that which is expected of age and results in one or more forms of incontinence, we call this a voiding disorder. And since the voiding pattern is not fixed up to the age of at least 4 years or 5 years, we like to look at any child over the age of 5 years who has an abnormal voiding pattern, and these children then should be referred. So another question that one would ask is, are voiding disorders common? So actually there was a survey of 2,000 children in primary schools in Australia, and the overall prevalence of voiding disorders was as high as 19%. So 16% had a mild disorder where they had only one wetting episode in about 6 months. But 2% reported that there were wetting episodes twice or more a week. And 0.7%, that's almost 1%, had wetting every single day. Now, this is in a primary school, presumably up to the age of about 10 or 11. but this is still extremely common and extremely embarrassing for the children. And they also found that there were certain risk factors for moderate or severe symptoms, which were recent emotional stress, something that a lot of our children are going through just now, a history of daytime wetting along the paternal line, or a history of wetting amongst male siblings were the risk factors in the development of moderate to severe symptoms. And what is also significant is that only 16% of the families with affected children sought medical help. The impression is that children are small, they will grow over it, they will mature, and very often, unless as primary caregivers, we ask the parents whether there are any problems in the children, we are likely to miss these. So what are the consequences of avoiding dysfunction? So social, most important. Embarrassment while they are in school, while they are in the company of other people, urine and bowel accidents. Other kinds of voiding dysfunction can also cause infections. It can cause vesicoureteric reflux. That is the movement of urine from the urinary bladder back towards the kidneys. It can cause damage of the upper urinary tract, namely the kidneys, which can finally progress on to renal failure. So there are many good reasons that we have for looking at voiding dysfunctions a little more carefully. So today we are going to discuss when you will suspect a voiding dysfunction, how you will investigate a voiding dysfunction, and as the primary caregiver for the patients' families, whether it is possible to start some kind of treatment. Now, when would one suspect that there is a voiding dysfunction? So there are certain standardizations of the nomenclature of these kind of voiding dysfunctions, and they are divided into two main kinds of symptoms, that is storage symptoms and voiding symptoms. If you go back to analyzing the basic function of the urinary bladder basically stores urine up to the time when it reaches full capacity. And when it reaches full capacity at a time which is convenient, it voids urine. So when either of these doesn't work properly, then you get dysfunction. So storage symptoms are when the urinary bladder doesn't store urine adequately well. And this is manifest by frequency of urine. It's urgency. When it becomes full, there's just an urgent need to pass urine. There's frank incontinence, or there's nocturia, or what was earlier called nocturnal enuresis. So frequency is when the frequency of urination should be between 3 to 8 per day in most normal children. If the frequency is less than 3 voids a day, or if it is more than 8 voids a day, this is definitely abnormal, and we should figure out why that is happening. Urgency, when there is a sudden, unexpected need to pass urine. Nocturia, a child who awakens at night to void. All these are manifestations of an increased frequency and something wrong with the storage capacity of the bladder. And as I've said earlier, all these are valid in children more than 5 years of age. So what do we mean when we say that there is incontinence? When there is incontinence, there is an uncontrolled leakage of urine. It can be continuous. So that means the urine just drips through the day. And that's always because of a structural problem. Or it could be intermittent. It means leakage of urine in small amounts through the day or night at unexpected times. And when there is incontinence at night, then we call it enuresis. The voiding symptoms are hesitancy, difficulty in initiating the void. You want to go and try and pass urine, but you just can't pass urine, and it takes a very long time to start this whole act of micturition. When there is straining to pass urine, when the stream is very weak, and when the stream is not continuous, it just comes as a staggered and kind of staccato kind of stream. That is something which is abnormal, because normally urine should flow out smoothly in one go. The other thing that one has to remember is that micturition and defecation are very closely interlinked. And together they are called dysfunctional elimination syndrome. There is a very high chance that urinary problems or voiding dysfunction and constipation are going to be associated. In fact, the association is as high as 30%. That means 1/3 of all children who complain of voiding problems will also have a problem with constipation. Now, why is that so? It's because both the rectum and the bladder share a very close proximity in a confined space, which is the bony pelvis. There's no place for either of them to expand. And if either expands, it's going to be at the cost of the other organ. Recently, there's also been a lot of research to show that there is a crosstalk in the neuronal networks between the two, that affection of one can directly through neural networks cause problems in the other. And both of them, of course, share a common control mechanism. The control of urine and stools both is through the muscles of the pelvic floor. So when one is working well and one is not working well, it definitely will affect the other one. So both the bladder and rectum, this is just to remember it, when the rectum is full of stools, the urinary bladder is going to be affected. And when the rectum is full of stools, the urinary bladder can't function properly. And so you get a crosstalk between these two organs. So if we want to understand what constipation is, we have to come down to normal defecation. We've already seen what normal micturition is all about. And the normal defecation means that ideally 1 to 3 stools should be passed every day. The form is supposed to be like a soft sausage. It has to have a certain soft or semi-soft consistency. And ideally, once you ingest food, there should be a minimum of 12 hours before that food appears in the stool. So in infancy, of course, toilet habits are completely unpredictable, but most children settle into toilet training by 2 to 2.5. We've seen that the stool control is achieved before urinary control. So generally by 2.5 years of age, you expect them to have fairly regular stool habits. And by the age of 4 to 5, you expect them to be completely continent of both urine and stools. So it's very important to ask about constipation. And when you ask a history, mothers will always say, oh, no, my child is not constipated. My baby passes stools every day and he's very regular. But then you get an X-ray done. And as you can see on the X-ray on the left, there are gas shadows and there is a lot of mottled matter seen almost entirely through the colon. And there is actually a grading system to grade constipation based on the plain X-ray. And if you look at the grading system on the right-hand side, you will find that the X-ray on the left corresponds to the most severe form of fecal retention or constipation, something that's definitely going to be important when you're assessing how well the child is passing urine. So how can constipation affect voiding? Constipation can cause incontinence, it can cause urgency, it can cause frequency. It is definitely involved in causing urinary tract infections. The commonest cause for acute urinary retention in a child is constipation. It can cause very high residues of urine after the child is voided. It means the child is not voiding completely. And it can even cause upper urinary tract dilatation on the ultrasound. So constipation is definitely a partner in crime in voiding dysfunction. So let's go through a few cases that I see in my OPD regularly. Now, this patient came just day before yesterday. This is an 11-month-old female child. And 3 months ago, there was mild fever with dysuria and hematuria. The child also started having frequency, would pass small quantities of urine every 10 to 15 minutes. The urine routine showed 50 to 60 pus cells per high-powered field, but the culture was not done. So very clearly, this child had a urinary tract infection, and you could pass on this frequency of micturition or urgency to a severe cystitis that this child had because of the UTI. In any way, the child was given antibiotics by her pediatrician and she settled down. So the diagnosis was a urinary tract infection with cystitis causing urgency, what we call the lower urinary tract symptoms or LUTs. However, 1 month back, the child had again these similar symptoms where there was dysuria and frequency. The diapers were always reported to be wet. This time, the urine routine showed no infection at all. So the pediatrician asked the parents to get an MCU done on the child. And there are these 2 pictures from the MCU. The bladder looks completely normal. It's smooth-walled. It's of an adequate capacity. The post-void film shows that all the urine has been emptied out very nicely. But what is significant in the post-void film, of course, is the fecal retention, which is again the grade 3 or the most severe form of constipation. And this child really requires treatment more for the constipation than for the urinary tract. This is a recurring story, constipation causing urinary problems. So coming back to voiding disorders, there is a very practical classification. And let's say that voiding disorders are of 3 different categories. The minor ones, which cause mainly just a social disturbance. There is no other damage that can happen. There are no infections, no fever, nothing else. There are lower urinary symptoms and embarrassment for the child. Moderate voiding disorders are those which have some effect on the upper system. It can cause infections and potential early damage to the kidneys, but the major ones are the ones which have significant renal damage, which can actually cause renal failure and be the need for later transplants in these children. So there are 3 or 4 types of minor voiding disorders. One is called the extraordinary daytime urinary frequency syndrome. There's one called stress incontinence, one called giggle incontinence, and a post-void dribble. And these minor voiding disorders are something which is eminently possible for a family doctor to pick up in his or her clinic and actually treat once you understand what is causing these problems. So in another case scenario, there's a 6-year-old male child who was absolutely well until recently. And then the parents complain of a sudden onset of passing urine every 15 to 20 minutes. He senses urine, he does not wet the underclothes, but has to keep interrupting his class or his play and running to the bathroom to pass urine. A small amount of urine is passed, and again he's back to normal. So there is no burning, there is no dysuria, there is no fever. And the significant thing is that he's completely dry at night. It's only during the day that he has these complaints of frequent passing urine. There's no past history of any similar attack. He's been completely all right since early childhood. He passes stools once a day, and those stools are quite normal. So what he has is an increased daytime frequency of passing urine with urgency, and there is no nighttime incontinence. When you examine this child, everything is completely normal. If you get a urine routine done, it'll be normal. If you get a sonography done, it'll be completely normal. And this child has a condition called the extraordinary daytime urinary frequency syndrome, which typically happens between 3 to 8 years. There is a sudden onset. The child needs to pass urine every 10 to 20 minutes. There is no wetting at night. The urine is not infected, and all investigations are normal. We don't understand the reason for this syndrome very much. It seems to come and go as suddenly. Medications are not of too much value, but some people believe that it's seasonal. Some people behave that it's got some behavioral component. It's, like I said, it's self-limiting, and all that you need is to reassure the parents and ask them to not be very strict with the child. Tell them that the child can't help it, and it's actually something that's happening, but it's beyond the control of the child, and it's something that will just settle down in good time. Coming to the other kind of problem, that's stress incontinence. So every time there's physical activity or a cough, it triggers a little bit of incontinence. And especially it's seen in athletic teenagers, generally in a high impact situation, like jumping or running. So say this young girl who's a teenager is training to be a runner, but every time she lands and has a high impact with the ground, there's a high impact landing, she'll suddenly pass a little urine. It's again very, very embarrassing for these children. And you would give sensible advice to say that, that there should be timely bladder voiding before exercise. Make sure that, before situations that trigger this off are caused, to make sure that the bladder is empty. And sometimes drugs to tighten the sphincters of the internal sphincters, sometimes useful and can help, but generally they just need support and reassurance. Something called giggle incontinence is a very strange condition, which is not quite like stress incontinence. But here, when especially young girls are sharing a joke or seeing a cartoon, and when they giggle or when they laugh, they get a sudden, massive and unexpected bladder contraction. This is not like stress incontinence where a little bit of urine may leak, but the bladder empties completely through and through their clothes. It's something that would be visible to people around. And it's something that may be self-limiting, but may persist into adulthood. This is something that we don't understand very well. And certain neurological drugs are used to treat this. But most of the times we have to, again, reassure our patients and tell them that they must learn to live with it. It's very, very hard socially for these young girls because they can't take part in funny situations in class or with their friends. And if they know that they're going to go and see a comedy movie, then they must make sure that they've avoided it completely before they do it. Again, something that can cause immense emotional stress to these children. Now, coming to the next kind of situation. So there's this 9-year-old fairly obese girl. And the parents complain that the panties are always stained with urine. There is always a foul-smelling discharge. There's local itchiness around the vestibule. Urine is normally passed all right. There are normal sensations and a normal flow of urine. But after passing urine, within a few minutes, she starts wetting her panties. At night, she's completely all right. People have advised her antifungal lotions, but with no relief. She's been given antihelminthics with no relief. She saw a urologist who advised bladder relaxant drugs. That also had no relief. And when you examine her, you find that she's a little obese. Her vestibule, that's the area around the vagina and the urinary tract, is a little inflamed and erythematous, but structurally completely normal. And the spine is normal. So when you look at a child with this kind of a history and this kind of a body type, you would be quite correct if you diagnose a post-void dribble or a vaginal voiding. So what happens is that the urine, instead of passing out, finds its way into the vagina and then it dribbles out on attaining the upright posture. This is typically seen in two types of girls. They are the small and very thin girls who can hardly manage to balance themselves on a Western style toilet. And there are the obese girls who don't spread their legs wide enough to allow free passage of urine. So the first picture refers to a small thin girl who's sitting in her WC, which is much too large for her. And she tends to sink deep inside the WC. To hold her balance, she has to have her legs very tightly together. And the second picture shows a girl who's sitting on the pot. Her panties are not taken down. She's a little obese, so her thighs abut each other. And that keeps the vestibule closed when she passes urine. Since the vestibule is closed and the urine comes out, it creates a little resistance and the urine tends to collect inside the vestibule and find its way up into the vagina. Then when she wears her panties and gets up, all that urine which is collected in the vagina will tend to dribble out and cause the wet and slightly smelly panties. So what do we do, or how can we advise these patients appropriately? So in the first case, generally when children are small, you would ask the parents to get a toilet seat, which allows the child to balance a little easily on the pot. Once the child has a proper balance on the pot, once the aperture in the pot is of an adequate size so that the child can sit comfortably, this problem should go away. In case of the other kind of girl who doesn't kind of take down the panties, a very simple maneuver will solve this problem. You must ask the girl to face the wall when she is peeing on the pot. If she has to face the wall, then she has to take her legs astride and spread them out wide on either side of the pot. And it will be mandatory for her then to take her panties down completely. If she adopts this, in most cases, the parents report a dramatic relief of symptoms. And this, just needs to be continued for a while till the girl understands exactly what is required of her. So these are 4 simple things that can be picked up in the clinic with a little careful history, a little awareness of what's going on. And even the remedial measures are fairly simple. And most parents will be reassured if you can explain this to them and treat these conditions. Now, when we move on a little bit to slightly more severe kind of voiding disorders, there are 2 types. One is a lazy bladder, where the bladder is is just not used to passing urine often enough for whatever reasons, what happens is that the bladder then tends to become a little hypotonic and large and flabby, and that there are less than 3 voids a day, but a lot of urine just keeps remaining in the bladder because the bladder loses the capacity to contract adequately. In contrast, there's an overactive bladder. It's like, I keep telling the children when I'm treating them, it's like your angry mother, where the simplest thing that you do causes like severe reactions in someone. Likewise, a little bit of urine comes into the bladder and the bladder will overreact, contract, and this urine is passed out. So let's talk about the lazy bladder, or a bladder which doesn't have enough urinary reflexes. It's a large capacity hypotonic bladder in an infrequent voider. So there's a decreased daytime urinary frequency. This child will want to void only once or twice a day, doesn't generally pee on waking up, which is something that's really common with everybody and is much the norm. But only later in the day, the child gets the urge and goes and passes urine. The child has to strain, he has a poor stream and will tend to be constipated. If you check how much urine is remaining in the bladder after he's finished peeing, you will find that a considerable amount is remaining inside, and this child has recurrent bladder infections. This kind of bladder is not very common. Only about 6 or 7% of children have this kind of lazy bladder. A little more common is the overactive bladder, where there's increased daytime frequency with urgency. And this may progress to daytime incontinence. Sometimes nighttime incontinence is also present. There are recurrent urinary infections, and there is constipation. A very peculiar thing that is seen in these children, and this is something that the parents will tell you, is that since the bladder tends to contract so often, and since it may not be comfortable for a child to pass urine then, the child will do all kinds of holding mechanisms to avoid passing urine. And the position in B is called squatting. The position in A is called a Vincent's curtsy. It's as if the child is doing a curtsy in the old English style. Some children will grab their penis to try and, to create a resistance to the urine coming out, or they may be rubbing up the clitoris, all in an effort to stop that urine from being leaked out. Again, the reason is not understood very well, but once this condition sets in, it sets a vicious cycle. Now, on the right, you see that man in the gym with these very, very hypertrophied muscles because he's doing resistance training. The bladder ultimately is also a muscle, the Detrusor muscle. And when the bladder contracts, and when the child contracts the external sphincter and tries to hold the urine, this contraction happens against a resistance. And so this bladder will become hypertrophied, it will become thick, it will decrease the elasticity of the bladder, it will cause high pressure in the bladder, and it will cause all kinds of repercussion based on this. So these kind of bladders can be dangerous. They can be bladders which cause trouble in the upper urinary system. And again, this whole condition is not very well understood, but we do know that certain kinds of foods, an excessive intake of caffeine, constipation, anxieties can cause these overactive bladders. Also, congenitally small bladders, bladders which don't have an adequate capacity, can be an overactive bladder. Now, just a little while back, we discussed bladders which have this extraordinary daytime urinary frequency, and we said that those were the mild and not a dangerous variety. But the overactive bladder can cause symptoms. So what is the difference between the two? An overactive bladder will have had symptoms for a very long time, whereas the extraordinary daytime urinary frequency happens suddenly. The important thing is that generally there is no nighttime wetting in the extraordinary daytime urinary frequency, but there is often nighttime nocturnal enuresis in the overactive bladder. An overactive bladder, there will be a history of recurrent urinary tract infections, which is not so in the other case. And if you do an ultrasound, you will find that there is maybe hydronephrosis in the overactive bladder, but not in the other situation. So this is how you would differentiate these two conditions. The second condition being a simple benign condition, and the first condition definitely requiring very active treatment. What is the long-term prognosis? Well, the incidence seems to be decreasing by about 15% every year after 5 years of age. But if it does not go down, then there can be lifelong symptoms, and a lot of urogynecologists are busy treating overactive bladders in adult patients as well. Finally, we come to the most severe kind of dysfunctions. And if you look at this MCU plate, you would find this large bladder with a very, very irregular outline. You would find that this child also has severe fecal loading, which the upper arrow is pointing at. If you look at the lower arrow, you will find some abnormality in the urethra because of holding urine by contracting the external sphincter. And these children also have a similar history of, say, dribbling since birth, of recurrent urinary tract infections, of a palpable bladder, very high post-void residue. And these are the children that actually progress on to renal failure. I actually have a patient now who's 17 years old and who is being worked up for a possible renal transplant because his kidneys have just gone completely bad. So you would say, what is the interest really in voiding dysfunction to a surgeon? Well, in some functional conditions, though most of them can be treated without intervention, in some cases, surgical management is important. And otherwise, in the investigation of voiding dysfunction, there can be a lot of structural abnormalities which actually require surgical correction. It can be a manifestation of a neurogenic bladder with a spina bifida. There can be anorectal conditions. There can be posterior urethral valves or other bladder conditions. And so as pediatric surgeons, we are very interested in knowing how these bladders are behaving and what the children actually have. So how would you really assess a child whose parents came with this kind of a problem? Now, we've said that any child above the age of 5 years who has voiding symptoms, like either peeing too often or not often at all, who has urgency, who needs to run to the bathroom every time they need to pass urine, who actually leak urine in their underpants, who have acute urinary retention, or who have urinary tract infections, recurrent infections, should definitely be assessed. Any child who has continuous incontinence, even if he's a little baby, if there is just urine passing all the time, then this child definitely needs urgent attention. And any child who has recurrent urinary tract infections with fever must be assessed by a urologist to find out whether there is any urinary voiding issue or other issues which are responsible for this. So how would you assess the child? Of course, you take detailed urinary symptoms. You try and find out what kind of a pattern this child had in passing urine. You would find out a history of toilet training. Has the child always had these problems, or has he been toilet trained and have the problems begun afresh? Is there a family history? Is there a history of any emotional trauma? Has the school been changed? Is there any bullying in school? That picture unfortunately shows that sexual abuse is another very, very important factor in dysfunctional voiding. And you must probe the child a little bit for this. A history of constipation, we've already covered that. What kind of a diet, what kind of a fluid intake, and whether the child is using diapers. How is the child coping with this voiding dysfunction? All these are important in trying to figure out what's happening. But one thing that you can ask the parents to keep, and which is of immense importance to any doctor who assesses this, is something called a voiding diary, which is a daily record of the urinary frequency, of the urinary volume, and of incontinence. So the parents actually keep a diary, and they, as soon as a child wakes up, the child is asked to pass urine in a urine measuring flask. And the time at which the child passes urine, the amount of urine that the child passes are all recorded. By the time the child passes urine next, if there has been any urinary leakage or any accidents, and all that should also be recorded. And all this gives you a lot of information about the pattern that this child is going through. More importantly, once you have a measurement, you can actually find out what the functional bladder capacity is. So how much urine is the bladder capable of holding? And then you can correlate it to how much urine should the bladder hold for that appropriate age. And that will also give you a clue as to how to manage this condition. So this is, as we said, all the important information that you get from a voiding diary. And this is something which is absolutely mandatory before treatment is started. In very little children, we do something called a 4-hour voiding observation. So we will ask you to send your patient to the hospital, and we will keep following these patients with repeated ultrasounds, let him run around, play, and call him back again for an ultrasound. Because in a small infant, it's sometimes very difficult to predict when the child is going to be passing urine and ensure that he passes urine in a measuring container. So on examination, there's going to be a general examination, of course. The abdominal examination is very important. You would check and see whether there's a palpable bladder. If you press on the bladder, is the bladder, does a child just become incontinent and pass urine on the table? You would try and palpate for fecal masses. Genitals is something that is very often forgotten, and it's of utmost importance to examine the genitals. It's very important to check out the anus. And the question is, would you do a PR, a per rectal examination? I think not, because doing a per rectal examination is something that is extremely traumatic for a child, and you would allow Salman Khan to say, "Maine pyar kiya, lekin aap pyar mat karna, please." Okay, turning the child over and examining the spine, again, something that's very important. And again, this image with actually the genitals hidden away is to remind you that the genital examination is very, very important. This child had an abnormality of the vulva and of the vagina, which pointed to a condition called a female epispadias, which was actually responsible for her having that problem. And unless you have the child on your examination couch and examine the vestibule carefully, you would not see this. Examination of the spine is also very important, because this child has this little hemangioma over the sacral area, which is a pointer to him having a spina bifida. And this is something which has caused a tethered cord and has caused voiding problems in this child. So all these examination maneuvers, a complete examination is really very important to try and figure out what this child has. The basic investigations are, of course, routine blood investigations, a test for kidney function, if this child has had repeated infections, and a urine analysis and a urine culture. A lot of our information and therapy will rest on this last test. And when you do a urine analysis, you would suspect if there was a urinary tract infection, if there are more than 5 pus cells per high-powered field, if the gram stain shows bacteria present, if nitrites are present, and if leukocyte esterase is positive. You would then ask for a gram stain and confirm with a culture and start empirical therapy while awaiting reports. Please remember to send the urine for culture before starting antibiotics, because otherwise you won't get a good culture. And I know it's challenging to collect urine in a small baby, but there are several ways in which we can do that, by attaching a urine bag, which is stuck to the patient's body, by actually catheterizing the child, by suprapubic aspiration, or by actually doing a midstream clean catch. I will accept that all these are challenging in children, but this is the only way to really get an adequate urine culture report. Catheterization or suprapubic puncture is the most accurate and is something which is normally done in a hospital setting if the other methods are not suitable. Now, the important thing for you to advise your parents is, when should urine be collected for a urine culture? Ideally, the early morning sample, because you want the urine which has stayed in the bladder overnight to be assessed for organisms. It's also important that the child doesn't pass urine in any container, then 3 hours later take it to the lab. You won't get proper results because there'll be contamination. So ideally, this needs to get to the lab within 2 hours of collection. And if it's not going to be possible, then you must ask the parents to refrigerate this sample and make sure that it is examined within 24 hours. Coming to imaging investigations, the ultrasound of the kidney, ureter, and bladder is like the most important investigation. It will tell you about the status of the upper tracts, about the bladder capacity, whether the bladder wall is thick, whether the posterior urethra is dilated. Generally, sonologists will have the child pass urine in the hospital and come back for a post-void ultrasound, and that will tell you whether the child is peeing completely or whether it's an incomplete void. Also, some good sonologists can also tell you about rectal dilatation. And depending on how dilated the rectum is, you would know whether this child has constipation or not. And we've already gone through this. Getting a plain X-ray of the abdomen is very important for two reasons. One is that you can pick up a spinal problem like spina bifida, which may be responsible for your voiding dysfunction. And again, in this case, this child has a lot of fecal loading, which you would also like to treat before you pay your attention to the urinary void. Another very important test, but which we use a little more sparingly, is the MCU, or a voiding cystourethrogram, or an MCU. And this is, of course, done under antibiotic cover, where we like to see the shape and the capacity of the bladder, whether there's vesicoureteric reflux, what the urethra looks like, how efficient the voiding is, and residual urine. We like to do these MCUs ourselves, because even while we are doing the MCU, there is a great deal of information that we get in these children. In rare cases, you may do other things like CT urograms, MR urograms, and MRI. In this case, an MR urogram has shown that there is one ureter which is coming down and opening much beyond the bladder. And this child had continuous leakage of urine along with passing normal urine. That's because one ureter was opening beyond the mechanism of control of urine for the bladder and causing a leakage of urine all the time. So in some situations, this is very important. Finally, we come to another investigation called urodynamics, which is used more often in adults and not so commonly in children. In urodynamics, we put in a little catheter into the bladder through the urethra, and then we have a machine that measures the pressures which the bladder generates as we are filling it with urine. And we get a good amount of information about the bladder capacity, the pressures and sensations during filling. We can correlate it with the expected capacity of the bladder for the age. And sometimes we can also include urodynamics along with an MCU. So we have a very, very clear understanding of how this urinary bladder is behaving. We have now a very, very good urodynamic machine for children at our hospital, at SRCC Hospital. And we will soon start full-fledged urodynamic assessment of children in the next couple of weeks. Occasionally, you might need to do a cystoscopy to rule out any kind of urinary or urethral problems. It also gives you a little more information about how the bladder is behaving and can be helpful in planning therapy for these children. So once you have finished assessing these children and you have an idea about what this child has, we start with treatment modalities, and all these general measures are measures that can easily be adopted by all family doctors, because ultimately they are the ones who will be seeing the children and the families very often. And the first thing is, of course, the treatment of constipation. We've said that constipation needs to be addressed first and free the urinary tract of all other external influences, and then we can pay a little more attention to the urinary system. Lifestyle modification, excessive carbonated beverages, excessive caffeinated drinks. It's surprising how many parents will take their little children to cafe coffee days and Starbucks, and the children are lovers of cold coffee, not a great thing for a child. Glucose biscuits, another very, very horrible thing for constipation in children, because they are made of completely refined flour, and parents will sometimes stuff their children's mouths with glucose biscuits. It's actually, in a couple of severe cases, caused a surgical emergency by causing an intestinal obstruction, which is it's possible that happens. Instead, adopting a lifestyle where there's more consumption of dry fruit and foods with fiber, healthy food. All these are important things, and that can be instituted in a family practice. Now, what about other treatment measures? So the picture shows you these parents punishing a child, and that's a strict no-no. The one thing that everyone needs to understand is that this child is not responsible. This child is not naughty. He is not purposely doing this, because whatever happens to children is extremely embarrassing in front of their playmates in class, and the child should under no circumstances be blamed for what is happening. Once we've understood what's going on with the child, then we advise several different kinds of measures like time voiding. For instance, we tell the parents to send an alarm clock with the child, which is set for like every 2 hours or every 3 hours. And the child must go and void whether or not he or she has the sensation. Sometimes we ask them to do what is called a double or triple void, where after a child finishes going and voiding and he gets up, within a few seconds, he must sit down and void again. Because sometimes if there's residual urine in the bladder, this will help the bladder to empty out completely. I've already spoken about alarm therapy. Some children need psychotherapy, especially those that have emotional problems. And biofeedback is another thing that some physiotherapists can do to try and sort out some voiding problems. Drugs are useful to control micturition. You have anticholinergic drugs that relax the bladder and increase the bladder capacity. You can have imipramine, which is also sometimes used for nocturnal enuresis. It increases the bladder neck tone. You have a whole group of alpha-1 blockers, which are used a lot in adult men for the treatment of prostatic symptoms, which also have some effects. But all these children need to be assessed very carefully before starting them on these drugs, because these drugs have specific indications in children, and using them loosely is not going to give us a very good result. Finally, there are some children in whom we have to treat self-catheterization. If these children just can't pass urine by themselves and they are resistant to drug treatment, what we teach the parents to do is to introduce catheters at a fixed time every day, every 3 hours or every 4 hours, in order to drain the bladder completely. This is used more often in children with meningomyelocele, but often may be required in children with severe voiding dysfunctions as well. And this is what we will very happily teach the children and the parents once we are convinced that this is the only way forward. There are other interventional therapies that we carry out, like urethral dilatation in some situations. We can do a cystoscopic injection of drugs like Botox, which actually causes relaxation of the bladder. There is another compound called Deflux, which is like a bulking agent, which helps to create bulk, say at the bladder neck or other areas, which can also be useful, again, with very specific investigations. And finally, there are surgical procedures which can aid in draining the bladder. These surgical procedures may be temporary or permanent. In the picture on the top, you see a gastrostomy button actually placed in the urinary bladder, because this allows the parents to open the button and drain urine, because the child can't do it himself. There are other ways of helping the child to pass urine and stools more effectively, which we will sometimes use in very severe cases of urinary tract, of urinary dysfunction. So the ultimate aim in our treatment measures is to make sure that there is an adequate interval between voids to allow normal social function for the child. He must be able to take a long train ride to go and meet his grandparents in the village. He must be able to sit through a movie without voiding. He must be able to sit through a game of cricket without having trouble. He must not be embarrassed in class by suddenly leaking urine. This child must not have any urinary tract infections. And most important, his kidneys should always be safe. So, is there a take-home message for you? Yes. The take-home message is that voiding dysfunctions are common. The incidence is about 15 to 20% in young children, so ask about them. Constipation is very often associated. Look for constipation. Don't treat the mother's response as there being no constipation. Examine the child very carefully. Look at the perineum and the spine. You can perform basic assessment in your clinics by having an X-ray done, a basic ultrasound done, and asking the parents to keep avoiding diary. And after that, if there is any suspicion that this is a significant problem, then this child should be referred early. We have every Friday morning a voiding dysfunction clinic with a full workup, including urodynamics possible. And we would be very, very happy to see these children and get them sorted out. Thank you very much.
Thank you so much, sir, for that enlightening, entertaining talk, and you've covered everything brilliantly. Since there are not that many questions, and you've pretty much covered everything, we'll close down for the day. I'd like to thank everyone for joining us today for this masterclass, and once again thank Dr. Amrish for this excellent talk. I'd like to again thank SRCC Children's Hospital, managed by Narayana Health, and the entire team for bringing all of this together. And again, as Sir said, please think of SRCC Children's Hospital for any childhood or pediatric conditions. I'd also like to remind everyone for next week's masterclass, that will be childhood backache, or how to diagnose backache in childhood and treatment by Dr. Sambhav Shah. So see everyone next Wednesday at the same time. Thank you so much, everyone, for joining us.
Thank you.